in the interest of full disclosure, I do need to admit that I am a card-carrying member of the Sno-Isle Library. And the question may very well be, why aren't you? As I was driving down here this afternoon, I do a radio program, a live radio program every day at 4 o'clock. So I didn't get off the air until 5. And so I had to drive down rather quickly through the rain to get here in time for this forum this evening. And as I was making my way down Interstate 5, I got behind one of those huge, luxurious RVs. I thought it was a double-wide mobile home that was making its way down the freeway. It was, along with all of the stickers on the back of it, that all of the different states that they had visited, there was another sticker that said, "We're spending our children's inheritance." And it occurred to me that that might be a very popular sticker in years to come to put on the end of beds in nursing homes and hospitals. We're spending our children's inheritance because of the costs of taking care of us when we get old. And that's part of the reason why we are here this evening. We are also here to talk about the need to make decisions now that will impact end-of-life, quality-of-life decisions as your loved ones, as we get older here. It can be overwhelming to be asked to make healthcare decisions for someone who's very ill or dying or no longer able to make those decisions. It can be even tougher if you don't have written or verbal guidance about those wishes, and sometimes verbal isn't enough. The lawyers, the doctors, family members are going to say, where is it written down that that's what she wants? But advanced care planning is not just about old age. A medical crisis can happen at any age and leave you or someone you care about too ill to make these decisions for themselves. Even if you're not sick now, making health care plans for the future is an important thing to do to make sure that you get the care you want, or, equally, you don't get any care if you don't want it, when doctors and family members are making those decisions. Tonight we have 4 distinguished panelists to speak on this very important topic. We have the library's executive director, Jonalyn Woolf-Ivory. Reverend Eileen Hanson is pastor of Trinity Lutheran Church of Mukilteo. Scott Forslund is director of the Snohomish County Health Leadership Coalition. And Joanne Roberts is chief medical officer of Providence Regional Medical Center in Everett. After opening comments from each of the panelists, we will spend some time talking with them. I will ask some questions of the panelists, and then we will open the floor to give you the opportunity to ask questions as well. And we are certainly urging you who are watching this stream to participate on Twitter. Feel free to Twitter questions in for the panelists as well. When the time comes for questions, I will ask those audience members to raise your hand. When the microphone comes to you, stand up. We'll have a wireless microphone for you. We'll ask you to identify yourself, whether you represent a specific organization, which community you come from, and which specific panelist you might want to address the question to, or if you just want to direct it to the panel in general. If you do have a comment that you would like to share prior to your question, that's just fine. We would encourage you to do that, but please keep it brief, and know that I will exercise my duties as moderator here to viciously rip the microphone from your hand and give it to someone else. So first of all, I'd like to ask each of the panelists to just take a few moments, introduce themselves, and talk to the topic at hand for this evening. And we will begin, I think, with the library's executive director, Jonalyn Woolf-Ivory.
Good evening. It has been a pleasure to be able to work with a number of different organizations to present tonight's evening. I am here as a non-health professional to share a little bit about my own experience in working with family members to make some difficult decisions, some difficult choices, but having the work done ahead of time to make that possible.
Thank you. Eileen.
I'm pastor of Trinity Lutheran Church, Point of Grace in Linwood and in Mukilteo. I serve on the steering committee for the Snohomish County Health Leadership Coalition, particularly representing faith communities, but also 70% of our county who is not affiliated with a traditional faith community, bringing more of the spiritual voice to the conversations of the various initiatives of the coalition. So for me, in terms of advanced care planning, I have been at the bedside of hundreds of people as they passed away and have seen very good endings and very tragic endings. And my hope in terms of having this conversation is increasing the number of good endings at the end of life.
Thank you. Scott.
Good evening. I'm Scott Forslund, and I'm here tonight representing the Snohomish County Healthcare Leadership Coalition, and am really excited about the work that the community is doing coming forward in this. Jonalyn, thank you for the work that Sno-Isle has done. This effort is focused on improving economic vitality and prosperity of our community more broadly through improvements in health and in healthcare value, but not through the healthcare system trying to pull a lever, but rather through the ability of each of us as members of the community to take back control over our own health. And the initiative that we're going to be talking about tonight is certainly an important example of that.
Good evening. Hi, I'm Joanne Roberts, and I am the Chief Medical Officer at Providence Regional Medical Center up in Everett. I am a hospice and palliative care doctor, and I've been doing this work in palliative medicine for about 20 years. And like Eileen, I have spent time with hundreds, maybe thousands now, of folks near the end of life. And what I've seen is that these times that we all fear at one point in our life or another are some of the sweetest, most wonderful times in our entire lives, and sometimes they're the most horrible. Families go through times of tremendous healing in the last days of their loved one's lives. Sometimes they go through times of tremendous agony. And I think my work with the Healthcare Leadership Coalition is to be sort of the voice of healthcare, although I don't think this is at all a healthcare issue. We are just technicians to your values.
Thank you. Let me begin by asking Eileen to flesh it out a little bit. You said, and also for the others as well, and for Joanne particularly, Eileen, you said that you've been at good endings and you've been at bad endings. Can you expand on that? What's a good ending? What's a bad ending? And what makes the difference?
A good ending is when the family has had a conversation about the end of life prior to entering the crisis. And they've had conversations about the values of the person who is dying, and how that person wants those values honored by all of the family. That includes the helicopter child in New Jersey who will at the last minute come in. In having those conversations, that child from New Jersey will still know what mom wanted and will respect the process that's been put at play by all of the family. There is a sense of healing, as you said, reconciliation of all the outstanding regrets. There's been the forgiveness, the expressions of love, and the sense of closure and peace, and the permission to leave. That's a good death, as I've experienced. The more tragic is if there has not been that communication in advance of the crisis. That's when you have the helicopter child who has unresolved issues wanting to stop the process. Say, wait, we can't let mom die or dad die. We need to intervene and suspend the situation. That raises a lot of emotional chaos, in which all of the crisis of the last 40, 50 years come into play, and all the childhood dynamics come into play, and there is what I would describe as a high level of conflict, a high level of anxiety, and that peaceful ending is surrounded instead by conflict. And that's the tragic ending. And it doesn't end when the patient dies. That remains an imprint on that family in a destructive way for years, and is very destructive to relationships.
Joanne, you want to?
Sure, I couldn't have said that's beautiful. Thanks. I'll put the technical side to this. I come from where Eileen is talking, but the technical side, let me describe what it looks like, and from the view that I've had working in the hospital. We all are going to get older. We're all are going to get more frail. And a common scenario is a couple in their 80s living at home. One maybe has dementia. The other one's the primary caregiver. The primary caregiver gets up in the middle of the night to help their loved one. They fall, they break a hip. The caregiver breaks the hip, not the person with dementia. They call 911, they get to the phone, call 911, comes into the emergency department. There's no one to have a conversation with. The person who's broken their hip is delirious. They're not able to speak for themselves. They go to the intensive care unit. They get their hip repaired. They get pneumonia. They go on a ventilator. They can't talk. There's no one to care, and the person at home is deteriorating. And then the family may be out of town. This is really common. This is so common in my world. This is more common than not, frankly. And conversations earlier could have prevented that. Not that it could have prevented the broken hip, not that it could have prevented the surgery, but it could have prevented the way that that journey occurred. So that when the pneumonia developed, it was pretty predictable. Perhaps it wasn't a time to seek aggressive care. Maybe it was in the values of that family, but perhaps it wasn't. Usually it's not.
Jonalyn, would you like to?
Sure. I think kind of following up on Joanne's comments about those conversations, none of us really look forward to having those conversations. It's hard to even think about losing a loved one, and it's even harder than to raise what I call the what-if questions. And in a time when people are really capable of providing good answers. And I think about the what-if questions such as, well, what happens, Mom, if you're terminally ill? How do you want to proceed? What if you're in a terrible accident? What if your body is doing great? You could run 100 miles, but your mind is not well anymore. And I did not, as the youngest child, want to ask those questions, but I think I had the good fortune of being in a family where those questions had been asked before. And so in the case of my father, who passed away a number of years ago, it was very clear what his expectations were, and that was clear to my mother and to myself. And what was the most helpful is that they had completed documentation that would allow his wishes to be taken care of. Even with all of that sort of set aside, it still required an advocate. He still required an advocate. And we still had answers or questions that we needed answered to. And I can remember when it became really clear that we were not looking for a repair or a fix. My mother and I needed to know what would the end be like? How would we know it was coming? And what should we do? I grew up on a farm. My parents still live there, so a long ways away from medical help. So what do? Do we call 911? We asked that question. Do we call the doctor? Do we call hospice? Do we call the mortuary? Thank heavens we asked the question, do we call 911? Because we were given some very careful and really thoughtful advice. And it was explained, discussed with us about what our goals were and what Harold's goals were. And if we wished for him to receive treatment, then we should call 911. If that was not his choice, then that was not an option that we should consider. And I think that one question was, and the answer that we got to that question was so very helpful for my family.
Now, was this an incident with your father in this situation where he was in ill health and the prospect of death was imminent? And would that conversation be the same conversation if your father was in good health but had a heart attack suddenly, unexpectedly? Do I call 911 or I just let him lie there and die?
Mm-hmm. Well, in this case, he was terminally ill, but those conversations had really happened before that. And so I think especially my parents, the two of them, had a very solid understanding of how they wished to proceed and what their values were. And I felt that as the daughter, it was my responsibility to make sure that the path that he wanted, he was able to have. I think if he hadn't been terminally ill and he had been in a farm accident or something, I still think we would have had a sense of how he would like to be treated. And I believe I can say that pretty confidently about that.
Scott, we haven't heard from you. Would you like to contribute to this portion of the conversation?
Well, I'd like to, but you're hearing from the people who I'm gaining from it. I'll tell you that. Maybe I'll put this in a little bit of context. So this initiative is focused, obviously, on basically giving people better odds of getting care in line with your personal values when you're facing a life-threatening illness or a life-threatening situation. It may be an end-of-life scenario. It may be something that winds up not being end of life. But it is, in any case, it's tied to issues that go far beyond the personal. What this coalition's interest in doing this is basically recognizing that as a society, as a county, we are faced with increasing threats in terms of resources needed for health care and a recognition that oftentimes the care that people want, if they're given the opportunity to think through it, is not in line with the default care that the healthcare system is going to provide. I think, although I don't like to use this statistic because it puts the focus on the point of death, and that's not what this is really about at all, but I think, Joanne, you've talked about the fact that something on the order of 70% of people, if asked, how do you want to spend your final days or hours, will say, I want to be at home, I want to be with family, I want to be in a peaceful setting. And yet, that occurs for about 30% of people. Now, for the 30% who want to, and I have some people very close to me who are in the realm where they're saying, you know what, I want to hang on as long as I can. I want to know whatever technology that can be used to keep me going is in use. The nice thing about this is that this is focused on making sure, again, that people are getting care in line with their personal values, whatever those values are, and that if that's happening, it's not only a more healing and positive experience for individuals, but it's actually a more healing and positive experience for our communities. The group of leaders who came together to form this coalition in a banquet room at Lombardi's up in Everett in 2010. This is leaders from business and from healthcare, but only 4 out of 13 on that board are healthcare. 3 out of 4 are not in healthcare, and that was intentional. Education, nonprofits, human services, the faith community. They came together and recognized that there's something as a community that we need to be doing to put our community on a different trajectory, not only to improve the health and healthcare cost issues, but also to improve the overall economy and in economic vitality and prosperity of our community. Gary Cohn, who's the superintendent of the Everett Public Schools, understood that night at Lombardi's and talked about the fact that this increase in healthcare risk and healthcare cost extending beyond our ability to pay is threatening and competing directly with our ability to pass school levies for kids. Troy McClelland, the Economic Alliance CEO for the county, talked about the fact that he recognized that these same situations are reducing the chances that state transportation funding can be available to help keep our key employers in town, which we know if employment and education creates a really virtuous cycle in terms of health and well-being. So they've come together to say, where can we begin with some initiatives like this that put the community in charge? And I hope that Eileen will talk a little bit about some of the work that's being done to create a network of volunteers that is YMCAs and churches and senior centers and others who are taking up this effort and really looking to take back control of our health.
Well, Scott, you mentioned that 30% of the people are able to have their end of life the way they want it. What separates the 30% from the 70%? What did the 30% do that the 70% didn't do?
And I just pointed to Joanne as you're beginning to answer that question, that I want her to answer that question. So.
It's a conversation. This is not rocket science. It is just a conversation. And I'm going to pose a question to you all. Who has sat at the bedside of a loved one near the end of life? Who considers it a healing experience? Okay, so maybe half. Maybe half. A conversation can make that a healing experience. So on the back of my business card, I carry 4 questions. And this is the 4 questions that I used in practice all the years that I worked. But imagine if you had this conversation with you yourself, with your family, with your doctor, with your friends. So the really core question is not about how do I want to die, it's how do I want to live the rest of my life? And what are my hopes? And what are my fears? And how do I consider my life circumstances now? If we can talk about those 4 questions, imagine going to a doctor's office and talking about those. Who's had that experience? I'll bet no one here. But we can. I mean, this is what we're trying to do in this community, is just get those 4 questions on people's conversations with one another, with themselves, with their families, and get the doctors to be ready to hear those conversations. It's not rocket science. It's just that simple.
How do you initiate? Is there a best time to initiate that conversation? Jonalyn, when did you have that conversation? How did that conversation with your father start?
I'm sorry. I thought he was talking to me. You go.
Actually, the conversation in my family probably started a number of years before that, when my grandmother was ill, and so there was it just became a topic of how we wanted to move forward in our lives and what was important to us. And in the case of conversations with doctors, I do remember going to the doctor's office with both my parents and having a conversation not unlike what Joanne was talking about. Is, these are the options. Harold, how do you want to proceed? And that was really a question that my mother brought into that examination room, and so that there could be a conversation, and then I could hear that as well as the physician.
Joanne, you wanted to speak just before Jonalyn started. So when do you have this conversation? How do you initiate this conversation? If your mother is 88 years old and frail, I can see that conversation could come up. But if your father is 52 years old and in good health, it's not a conversation that's going to be an easy one to initiate, but he could be in an accident the next day.
Well, I can tell you, this is the conversation I had about 15 times a day for about 20 years. And it's an easy conversation to have, really. If walking into someone's room in a hospital or in my office when I was in primary care and say, "So tell me what's going on for you," you'd be amazed at what people say to that. We have a conspiracy of silence between doctors and patients where no one's really willing to fess up. But if someone just says, so what's going on for you? I probably half the time in the hospital when I'd be called to see a patient, they'd say, "Well, I'm dying, doctor." Sort of makes the conversation easier to have. And I had this, I'm like you, I had this conversation with my parents. I grew up in the South where death is, it's kind of a sport. I think going to funerals is what you do in the South. And my mother, I used to be the one to go around, "I don't want to talk about it, but my mother talked about it constantly. And at the end of her life, she was worried because the doctors were saying, we think you need this device in your heart. And I said, "Mom, does that fit what you had said all the years?" Oh yeah. And she died a couple of days later. It was just very sweet.
We're going to open things up to questions from the audience. And so if you do have a question, please raise your hand. We'll get the microphone over to you. And please stand. And if you are with an organization, please let us know with what organization. And if you have a question, to whom you would like to address the question.
Why? My name is Rita Miller, and I'm representing a conversation we had at the Senior Center in our current issues class this morning. The idea of dignity with death came up, the law in Washington State. I would like someone to say exactly what the law is, and then there were people in the class who believed that not only could the hospital override your written directive, but that certain hospitals, which are ruled by certain religious groups, would indeed keep you alive despite your written directive. I would like the answer to this, please.
That was on 60 Minutes this last Sunday.
I'm talking specifically
I'm just going to answer this one, am I?
Person who gave her father morphine in Pennsylvania.
I want to know here now the answer.
Oh, no, I'm not arguing.
Joanne, can you
I
speak
think
to
I'm
that?
supposed to take this question. So yes, I mean, I have talked about this at length. I've given lectures about it, and I'll represent Providence right now because it's a Catholic health organization. I don't know the particulars of the law. I mean, I know basically you have to have your cognitive ability, you have to request it, and there has to be a waiting period and a second physician involved. But I don't know exactly what it is. I have worked with folks at Compassion and Choices, but, you know, I have never prescribed, nor personally will I, because being a palliative care doctor, I really believe that, first of all, physician-assisted suicide can be an easy out for the system. I want to make sure that the system is able to provide the care that folks deserve and really want. That said, I do believe that these conversations around death with dignity are wonderful opportunities for that conversation to be had. So when someone, and I've had 2 patients ask me, and all of the time I've worked in this field, I've only have had 2 patients ask me. I work in the hospital, so people usually don't have their faculties when they come to me. But the 2 patients I sat down and said, so tell me why you're asking. Tell me why you're asking. Neither patient followed through, but I would have been perfectly comfortable to have the conversation. Providence as a system, and I think I could speak for all of the Catholic systems that work in Washington, they don't get between a doctor and a patient. What happens between a doctor and a patient is sacred, and it's considered that way by the organization.
Are you saying don't ask, don't tell?
No, I'm not saying that at all. I'm saying what happens between a doctor and a patient is sacred. I mean, it's not an organizational decision. It's a personal journey.
Scott, is this on the agenda of the Snohomish County Health Leadership Coalition, this issue?
It absolutely is on the agenda, but it's a pretty simple question to ask, and it goes back to what I'd said earlier. What this is about is giving people better odds of getting care in line with your personal values, whatever those values are, when you're facing a life-threatening illness. And what you've heard from a pastor, and what you've heard from a physician, and what you've heard from a community leader and an individual are 3 perspectives on the fact that many times the healthcare system, and it's not just the Catholic healthcare system, by the way. If Kathy Clapp from Swedish Edmunds were here tonight, she would talk about work that Swedish Edmunds has done with a fellow named Dick Stewart, who's a part of this coalition, working to do the same kind of work as a part of this work. Because of what they see, she said, so often I will see people come into the emergency room and see the process that they're going to walk through and ask this physician what that default process is. And she said it is heartrending. And I asked myself, why didn't this person have these conversations? Why didn't they have an advocate in place? Why didn't they have the advanced directives in place so that they could have what they wanted to have? But instead, they're going to have what the default is that we have to give them. So the simple answer, again, to this is, if you know what the issues are, and sometimes they're not that easy to anticipate. For instance, a ventilator. What is it about a ventilator? Well, one of the things I've heard about a ventilator is you have a ventilator and you can no longer communicate with your loved ones. You can't talk anymore. And depending on where a person is in their life, that might be a really important thing, that they're able to talk. So it's getting clearer on some of the practical issues associated with choices or decisions that you will have to make, having conversations about your own personal values, having conversations with your loved ones to ensure they know where you're coming from, making sure your physician is aware, and then you've got a better shot to answer your question directly wherever you're at, whether it's a Catholic health system, whether it's not, of getting care in line with your personal values. Death with dignity is kind of a non-issue from the perspective of this coalition. We're not for or against it. What we want to make sure of is that people are aware of their values and have a better shot at getting care in line with those values, and that takes some pre-planning.
I have another question here in the front.
I'm Carol Spade, and I'm with Friends of the Mill Creek Library. And in relation to the question that was just asked, my husband went into an outpatient facility for a minor, outpatient acceptable procedure with directives, and we had to, at that point, sign a paper saying that we realized that this facility did not honor advance directives, et cetera. And my question is, how can that be lawful?
So that is a pet peeve of mine, and it's about, so where that discussion comes from, and I was just having it with a friend at the Everett Clinic the other day who's another palliative care doctor. Where that comes from is the anesthesiology community, because when we undergo surgery, we are receiving the same technology as we might receive during a resuscitation procedure. So we're on an artificial breathing machine. Like Scott said, you can't talk during surgery, you're unconscious. Your life is being supported by another human being during that time. The anesthesiology community feels that that is equivalent to resuscitation. So if you insist that you can't be resuscitated, they can't give you anesthesia. I don't particularly agree with that interpretation, but it does seem to be common. It's not about organizations, it's just about one view of one, and it's just about the surgery itself.
And so how do you get around that?
We have conversations, many conversations, and yes.
I think just building on this a little bit too, we can, as members of a community, take back control of our own destiny broadly, and certainly of our healthcare choices. And it's not a perfect system. And becoming aware of what some of the issues are, and being in a place where you've got a better shot based on the cards you're dealt of getting what you want, but ultimately being in a place where you can help to influence policy, to ensure that the game rules, if you will, are more amenable. That's where this is all kind of going. And the fact that you are all here tonight is probably the most profound and important piece of this. We've got to have this become a public conversation, one where we are equipped and we're calling the shots. So,
Any other questions?
Can I just say one more thing about your question? I mean, to get to Scott's point, we're obviously not serving you well if we can't adapt to your values. I mean, to be blunt about it, and that's what we have to learn. Is that it is your values, and this again, it's not about the end of life. It's about what's important in the journey between here and there, and that's on us.
What do you do if you find yourself in a family where it's not okay to talk about these kinds of things, and you try and talk to a parent or to a sibling or uncle or aunt or someone you care about, but every time you bring it up, they say, "What are you trying to do? Kill me off early?" or "I don't want to talk about that right now." But you can really sense that the time is coming where you need to have those things in place, but they're not really willing to do it. How do you move them towards that, or do you at some point decide, well, if we can't talk with you, then we need to talk amongst ourselves about what we do going forward?
Before you answer that question, could we get you to introduce yourself?
Oh, I'm Ken Harvey, and I work for the library district, but I've got an aging mother and mother-in-law.
Could I take a stab
Absolutely.
at that? I just met with a fellow pastor this morning about hosting conversations in the church. She wanted to have this conversation, the classes that the coalition offers, in early December prior to the holidays, so that they could normalize and move upstream that conversation before you're in a crisis situation. The document and tool that we're giving our classes to kind of begin those awkward conversations. We hear it from children who have concerns about a parent, but also a parent whose children wants them to be immortal and serve cookies forever. So one of the documents that we give in the class is the advance directive. Again, a document that that translates the conversations. What we don't start with is we have a choice of who's going to be your healthcare agent and what are the medical treatments that you want. Don't start the conversation with that legal emphasis. Instead, we go to the latter wishes, which is my wish for how comfortable I want to be. And it's like I wish to have my favorite music played. Whenever there's a conversation about music, Mom, you love jazz. You know, is that something that would be comforting for you? I had one person who wanted Chanel No. 5 in their room. How do you start with Chanel No. 5 as an entry point into the conversation? Another person loves their pet and had talked about how comforting that pet is to them. How do you enter through those sorts of normal, everyday window opportunities of how comfortable you want to be? Another consideration is how do you want to be treated? And what I wish the fifth wish is my wish for what I want my loved ones to know, which always starts about love and forgiveness and reconciliation and healing of relationships. So how are those entry points into the more legal aspects of healthcare agent and medical treatment options? And those opportunities exist around a holiday table, but also at the beginning of New Year's and resolutions and throughout the whole year, in very simple conversations if you're intentional about it. And that's what we're hoping to do in the classes, is equip people in meaningful ways, in take-home information ways, to equip them to be ready for conversations with loved ones as they arise or are more intentionally scheduled.
Is that pamphlet that you were referring to available online? How would someone get a hold of that?
Attend our classes that are scheduled. There's a sign up I saw at the front for attending classes, but we offer these. All of this information is freely given and shared. And the hope is that if we were just to distribute it, you would not have the education conversation about how to actually use it and how important it needs to be in terms of a longer process of conversation, reflection on values, and then documentation.
Well, let me explore the concept of the family dynamic a little bit more, because this conversation is taking place between a mother and a daughter, a mother and a son. The brothers, the sisters are scattered all over the country. When the final decisions are being made, whose conversation takes precedent? Who does the doctor listen to? Mom would never say that. I know Mom would want to live. She's the fighter.
That's why all of these conversations need to happen upstream with all of the people involved, even the estranged one that's difficult to talk to. You've got to be able to engage. So it's not only the child or the relative or the spouse or the neighbor who's designated as a healthcare agent. It's also all of those who were not, who can support and understand what the person wants and be supportive of that healthcare agent, again, to avoid those conflicts and tensions well in advance for when you're in a crisis.
And does that information, you mentioned documentation, is it enough if Mom hand wrote on a piece of paper?
Absolutely, as long as you have two witnesses.
And for the doctor, in this dynamic, you're in a room with the children, and they're not in agreement as to what happens or what should happen. What role are you as the doctor going to take? Are you as the doctor of palliative care, well, we're going to do everything we can to keep her alive for as long as we can.
Right. And what I try to do, first of all, I think families die the way they live. So whatever dysfunction there is, and all of our families have some dysfunction somewhere, those get magnified at that time. And that's what keeps me in this work all these years, is to work with families during crises like that, when the dysfunction really is showing itself, and to help bring them back to what Eileen said. And the easy questions are, well, what would your mom have said? What would your mom have said? And when there has been a conversation, then it becomes, what did your mom say? What did she say? And then the families, they listen to one another. And even if they disagree, at least they'll know what their disagreements are, because not all wounds are healed at that time. But if at least the values have been shared, and it's the person's values who's actually going through the death, it shapes the family's values too as they have the conversation. It's amazing to watch these conversations.
And the advocate that was mentioned earlier, where does the advocate come from, and what role does he or she play?
The advocate or healthcare agent or durable power of attorney for healthcare, there are many terms to give to this person. The qualities that you're looking for in this person, a lot of people default to either spouse or child, and we just encourage that they expand their circle of consideration, because what you're looking for is qualities in a person. Can this person handle stressful situations with a lot of changing information? Will this person actually live out your values and not their values? Are they able to listen and advocate for you, even if your values may be different from theirs? Are they within relative, proximity should you have a crisis? What we advocate for is not just one healthcare agent, but a secondary backup healthcare agent, and sometimes a third one. Just to make sure there is someone there to respond with a consistent understanding of what that individual wants.
And to find this person, what super term do you use on Google to have this person's name come up at the time that you need it?
Right. Well, it's okay. I'm just referring to our kit again. What we have is a healthcare agent information form that kind of spells out the responsibilities and expectation of that healthcare agent that the person can actually give that person and say, this is what's expected, and here's some of the questions that we can engage in to prepare you for that. It's an imperfect system, but we also have wallet cards that people can carry around that says, this is my healthcare agent, here's their contact information, this is my physician, I have an advance directive, here's a document, here's where it is, and this is where it's filed. So it's trying to, again, equip the public in as many ways as possible to let the medical team know that they have an advance directive. Here are the people who will speak on behalf of me if I'm unable to speak.
And here's where you get to stop being the audience and start being engaged, because, and maybe you can take a moment and talk a little bit about the network of volunteers who has been put together, who's trained and certified right on from the Washington State Patrol background check through personal counseling. And these are, I think you'd mentioned the Edmonds Senior Center this morning. Michelle Rayton, who's an MSW, who's with the Senior Center and has been trained, certified as a volunteer facilitator and is teaching these classes. Terry Huffer, who is a YMCA senior programs manager at the Mill Creek YMCA, who has just gotten on fire about this and has the whole Silver Sneakers group onto it. So maybe, Eileen, you can talk a little bit about the network you're building and the offer that could be in front of all of these people, too.
This is a grassroots community effort. There is education among physicians, but in educating the public, our hope is to reach 1,500 people every year. And that is not a professionalized effort. That is a volunteer grassroots effort in which we need the community to come together. We are training volunteers in 4 different roles. One is to facilitate the classes, if you're comfortable with that. The other we're calling docents, which are more of the individual people who love individual conversations that can troubleshoot any questions that come up as that person considers advanced care planning and documentation. We need community advocates in all of the different social works. If you belong to a Rotary, can you advocate for this conversation in introducing at least the movement within a Rotary setting or a faith community setting or in a gym setting or in your place of employment? And the fourth one is, again, administration. This takes administration, just in keeping, if you're good at office work and tracking details and information. We need all those 4 different roles, and again, it depends on volunteers from the community who think that this is an important conversation to have.
And contact information for you on the table in the back?
Yes. Yes.
Other questions this evening from the other? We have a couple of questions. Go ahead, sir.
Hans Donkers. I'm a retired family physician. And I'm sorry I interrupted, but I just wanted to put a plug in for last Sunday's 60 Minutes. It dealt with the states that had aid in dying, gave a very poignant example, but then had a really very excellent Dartmouth physician who talked about that basically palliative care, if someone needs to die, then it's a kind of a failure of palliative care. So, and I also wanted to put in a plug for the People's Memorial Association. It's a 1939 founded cooperative for funeral homes, and it's a discount, and it recognizes, it was formed because at the time of death, the last thing you think about is price, and you're just very vulnerable to being upsold. And so I actually have a few pamphlets on the People's Memorial Association back there.
All right, thank you very much.
Hi, I'm Marcel Allen, and my question is, how easy would it be for us to get one of those cards Eileen was talking about when we got our library card? Make it easy, start it young, because I'm 32 and I put 2 people down this year, and it was not fun. And it's got to start young, because this room, I'm the minority in age, and the younger people need to start it with their library card. That could be so easy, couldn't it?
Perfect.
Or the driver's license. How long is a document that we would be talking about dealing with these issues valid? If something like that is made in your 50s and now you are in your 80s, but you are unable to articulate, is that valid? Is that going to take precedence over a conversation that you had with a daughter that said, you know, I've changed my mind since I made that, and I want to go for broke and be kept alive as long as possible? Which takes precedent, and how do you work with something like that?
You know, one question is how long is it valid? I guess another question is how long should it be valid? And Joanne, you've talked about even when folks think they've kind of worked through this, maybe they haven't.
So what Scott's referring to is there was a study done years ago, back when I was in fellowship, of spouses. So who should know my values better than my spouse, right? So they surveyed spouses and they surveyed the patient, who I don't even know how they did it now. But what do you think the error rate was between spouses' wishes, the spouses' values for what they thought their partner wanted and what their partner said that they wanted toward the end of life? What do you think the correlation was? It was a coin toss. It was right at 50-50. And it was a yes-no kind of question. So, I mean, this was not a subtle study. And so I think it shows that
So the question was what?
the importance of the conversation. We think people know. We think our families know. Well, they've lived with us their whole lives. They don't know. They don't know. The other thing, I don't know if anyone was at Atul Gawande's talk on Monday evening down at Town Hall. He cited, he's the author who's written on patient safety. He's a cancer surgeon who has just recently, he's a young surgeon, he's just recently seen the light in this area and realized, my gosh, there's a conversation to be had here. And he cited some research that I think is just so provocative, and it fits with my life experience, and I bet yours. There's a researcher at Stanford and looked at the values of people in their 20s and then followed them and looked at their values again as they aged. Just what's really core to you? And in their 20s, fame, going to a bar at midnight and listening to loud music, fortune, those were the big values, grasping life, holding life. By the time people are 50 or 60, they use words like intimacy. Fame, the fortune goes away. And so, getting back to your question, how long should these be valid? I don't know the answer to that, but 20 years is probably too long, because I don't think my values are the same as they were 20 years ago. I bet none of yours are either.
What we recommend is seeing the advanced directives as a living, breathing, changing document that should be reviewed regularly once a year, just to see if your health has changed, your relationships have changed, your priorities have changed. It's very organic, and what you do in your 20s is not going to be what you do in your 50s or your 80s, and just continue to have the conversation. Don't rely only on the documents. Have the conversation on an ongoing basis throughout your life, and let that document change as your conversations change.
Question in the back.
Yeah, I'm Charles Pratt, and I'm with the library system, but I'm also monitoring the conversation on Twitter, and we've received some questions there, a lot of which have been answered, but this is one that I haven't seen spoken about as much, and it's from Marcel in Mount Vernon. And she asks, how can we better plan our journey even if we are young and our network is young? And do you have any resources you'd recommend for people under 40 who are thinking about making these kinds of plans?
Under 40 resources. I think you go through the same conversations, the same process as you think about a healthcare agent, just which is actually challenging for people in their 80s who may not have loved ones in their 80s. But you think about just the qualities and characters of people, but yours would be changing a little bit more regularly. I really am excited about your energy, about talking about this. My 19-year-old said, you know, Mom, we should have, I should be doing something like this. So it's 19, it's 40. Last year, I was in a car accident with a mild traumatic brain injury. Stuttered, couldn't understand a lot of people. You don't expect that, you know, in the prime of your life. Accidents happen. And that's why I advocate. I think the process will be the same in reflecting on your values, reflecting on medical options. Obviously, a little bit more intervention may be appropriate if you are in good health and not facing a chronic progressive disease. And then translating that into an advanced directive.
And if I could just build on that, again, I loved what you said as well, and that notion of you know, how would you like to influence the direction of this movement, of this work, in a way that aligns with your personal values, or that would kind of advance your objectives or your concerns. There are a number of different forums that are fit to different groups. There's something called the Death Cafe. It's a death dinner party, basically. That get on, Google it, and you'll see. So this isn't just sort of the conventional It doesn't have to be that way at all. Also, work that the coalition is doing is experimenting with, again, with other sectors, other work groups. Jim Steinruck, who leads the senior services for Snohomish County, is working with an organization in Linwood, the Center for Healthy Living, that's been funded by Verdant Health Commission. And in that organization, there are groups of first-generation, multi-ethnic families and friends that come together, and so we're experimenting with that, because oftentimes there can be cultural values that can be very different. So what I loved about your point there, and what I would ask you and all of you, is think about how do you want to engage in a way that's meaningful to you and that can kind of move this ball forward a little bit. It can't be done by somebody else. Joanne is doing yeoman's work through the Prov Health System and with her vision and her leadership. Jonalyn, through what's being done through the library system, is I think taking these issues out in unconventional and important ways. But you know best how to reach your own peer group and your friends. And that's what Terry Huffer at the Y said. I know this Silver Sneakers group. They trust me. I'll talk to them. So.
Is there anything, and this is for all of you who have carefully read both documents, anything in the Affordable Care Act, Medicare or Medicaid, that addresses these issues at all?
Well, the Affordable Care Act, as you probably remember, this is the infamous death panels, that there was a provision in the Affordable Care Act originally to pay doctors a little bit more for having these conversations, but the death panel people came along and that was taken out of the bill before it went for a vote. What is going on in the state is something I would like to mention, because I think it gets back to the driver's license issue. There is a group called the Bree Collaborative in the state, and they make recommendations to the governor about tying Medicaid payment to various issues around healthcare quality. And one of the issues up right now in the Bree Collaborative are some recommendations around care toward the end of life. And one of the recommendations is actually to put some of this on driver's licenses. Those kinds of things get me excited, because they're not going to transform the state, but they'll help. So I think it's still open for public comment, the report for the Bree Collaborative about payment. And if you Google Bree Collaborative, you can, it's B-R-E-E. It's named after a doctor named Robert Bree, who was very, very committed to improving the quality of healthcare in the state.
And specifically, what are they talking about putting on the driver's license? I'm already an organ donor, and it says that right there on my card.
The fact that I have an advance directive doesn't mean it's going to be honored, because it might not be able to be found, but at least it's evidence. Because I tell you, on the receiving end of this, or the EMS folks who go out to people's houses, they just don't have any evidence at a crisis. So any evidence is better than what we have now.
I do think it's important as a family member, if you have that documentation and that evidence, you shouldn't assume that it is automatically going to happen. I was in the hospital with my mother, and she had been sent from a memory care facility because she was having trouble breathing. And I overheard the medical staff talking about her and commenting that she did not have a do not resuscitate order, which was exactly the opposite of what of her wishes and what the documentation that we had available. And it was extremely important that I address that issue at that point in time. No one else was going to address that issue, and we can't assume that there is this paper trail that moves along with folks.
Yeah, that's so true.
Yes.
Carol, again, just in comment to that, we had a nurse in the emergency room suggest that when this issue was over, that we take our advance directive to the emergency hospital and have them scan it into the record so it would be there, and I wouldn't have to physically take it with us at some point in time.
Yeah, the extent to which advance directives are universally available varies from state to state. I think Utah, Oregon are a couple of states that are a little bit further along than this. There have been some efforts to create repositories, public repositories, actually in Washington State a few years ago that kind of petered out a little bit. That's also a part of what we're looking at as a coalition, is how to try to help move that ball forward. Organizations like Providence are very, they've got some IT systems, some info technology systems that make it so that I believe if you go into an emergency room at Swedish Edmonds or Swedish in Seattle or Providence or St. Mary's, there's some likelihood, is that correct?
So that's another reason why I think Snohomish County is so poised to move this work ahead. We're a very, very, very connected county when it comes to electronic medical records. So the Providence system, Swedish, the Everett Clinic, Edmonds Family Medicine, I believe, Group Health, a couple of the specialty groups are all on the same medical record platform. So things can, if you do something at the Everett Clinic, it's able to be read at Providence or Swedish. And most communities are not nearly as far along as we are in that.
Very briefly, then we'll want to go to this lady here.
There's actually an app that you can get on your phone. It's actually through the American Bar Association. It says something like My Wishes. Anyway, you have your advance directive on your phone. And then the other plug for the People's Memorial, they'll have your advance directive. They'll also have your funeral plans on record.
And so will the NSA, but that's another story entirely.
I just had a quick question. So should you, oh, sorry. I'm Debbie Murchie, and I'm an employee of Sno-Isle, but I'm here on my own. Just curious, should you give a copy of your advance directives to your primary physician as well as, family members?
I think so. I think the more people who know, the better. I'm less of a document fan. I mean, over the years, I found documents not to be helpful, other than promoting the conversation. That's how to me as a provider, that's how they've been helpful, is promoting conversation.
So we laminate copies and put it on the refrigerator and pass them out to our neighbors and all of our children?
That's exactly what we do with the Pulse form. So who has heard of a Pulse form? Yes, that's great. I'm so glad to hear it. So a Pulse form it's not an advance directive. It speaks to the hierarchy of healthcare, but it's a physician's order. And patients have to co-sign it, or their surrogates have to co-sign it. But it spells out the goals of care in a very concrete way. It's bright green. Is there a copy in the packet? Okay. It's very bright green. You can't miss it. You can see it from across the football field. That's exactly what people do, is they put them on their refrigerators. So the EMS officers, who are usually the ones who are in the most difficult situation, the EMS officers walk in, they see it. They know to look for it. Our EMS officers are trained to go look for that lime green document somewhere in the house.
And where does one get
honor
that
it.
document?
That document can be had at any healthcare provider. You can go on the Washington State Medical Association website and get it. You can download it, although you can't do it in color. But any healthcare provider now has a Pulse form.
Any other questions in the audience? We have another.
So I have two questions. I just want to ask these together. My wife and I have a very good friend in her 30s who has been battling her second bout of breast cancer, 10-year-old son. And so their family certainly face-to-face with a potential terminal illness, although she seems to be doing pretty well now after, with the treatment that she's been receiving. So that's very good. But when you're thinking, so with this family in their 30s, when you're trying to plan ahead, How do you plan ahead for all of the potential financial costs of different types of illnesses or diseases or even accidents that might leave you paralyzed or whatever? How do you financially plan for those kinds of things? And is there a way of even having an opportunity to look at the types of forms that the physicians or their staffs might put in front of your nose if you're in a critical situation and they need to do something quickly and they want you to sign off on it? Can you look at any of those forms in advance so that you're not doing it under stress when you may not be thinking as clearly as you'd like to?
I think that the financial issue is tragic. It's just tragic because I think we all know that the bankruptcy rates are highest in healthcare related costs. That's where bankruptcies occur these days. It's in healthcare related costs. And it's made worse because healthcare costs are not transparent. Now, ask your doctor how much the CT scan that he or she orders costs. They can't answer. And because they don't know. It depends on your health plan. It depends on where you get the scan. So it's just a tragedy that we're suffering through as a country right now. To get back to your question, I do think that we have to be consumers of the system, and that the system is only going to respond when people push on the system to respond. It's the whole system is misaligned right now in that regard. As far as the forms are concerned, again, I think being a consumer and saying, why do I need to do that here? What reason would I need to fill out a form at a doctor's office? Why not take it home and bring it back or mail it back?
Question in the back.
Hi, Eric Lindsay. I think it would be interesting to see what other countries are doing. I've followed the United States quest for universal health care for a long time, and what I felt with the Clintons' initiative that they missed is they missed the opportunity to have a Ronald Reagan type fireside chat and educate the United States that one way to look at what has happened to healthcare in the Western world is that with the Marshall Plan after World War II, we helped rebuild and then prop up all of Europe, and one of the first things they did is they gave every one of their citizens universal health care. We paid for it in a way. Why didn't we give it to ourselves? Or why don't we give it to ourselves? I think if Hillary Clinton and Bill had pitched it that way, there would have been a chance to get it during Clinton's administration. I think that having lived in other countries, I've seen the way other countries do it. I think what you guys are doing tonight is fantastic for all age groups because I've known people in my life that suffered cataclysmic health reversals in their 20s and 30s. And I had a sudden onset of extreme peripheral neuropathy in my lower legs 2.5 years ago to the point where I couldn't talk. I was in so much pain I couldn't think, and it took a big gap out of my life. I also think that there's a tendency, from having lived in other cultures, there's a tendency of Americans to think that we're coming upon a problem for the first time, that no other country has come upon it. And I think it would be interesting to do a study and see what have other industrialized countries, what have other countries done with health plans. What have they done to address this? Now, if you're talking about the 20-something, this is an age group. I set a goal when I was 22, and that was never to take on the mindset of, an old fart and tell young people to turn their music down. Now, with the exception of violent rap, which I will not listen to in bad country, I'll listen to good country, but not bad country, I've held up that bargain with a buddy of mine. We've stayed current with pop culture and whatnot, and if you really look at the 20 and 30-somethings, the millennials, what is easy for them is obviously technology, applications. And I think that if the affordable health care applications for health plans are made electronic, which they are, then these type of advanced directives could be a part of that process, and that would be the most seamless way to make it universal. People wouldn't have to have this, I'm bulletproof, I'm never going to die, subconscious mentality. I know I'm going on here. 12 years ago, almost to this day, my father passed away.
Do you have a point that...
Yeah, I do. 12 years ago, almost to this day, my father passed away. He had an appointment a month after he passed away to do a living trust and a living will. So I think that what you're doing is great, and what plans do you all have to take this even further and get the word out there to the lower age demographics?
Perfect place to bring the program to a close. Thank you. And I think it's also a perfect idea for future issues that matter, the cost of health care and dealing with the cost of health care. Because I ran across while I was reading up about this, 25 years from now, when most of us, 20, 25 years from now, are going to need it, a private one-bedroom in Washington State in a healthcare facility is going to be $24,000 a month. Think about that on your way home tonight. What I'd like to do now in wrapping this up is thank all of our moderators and go down the path and ask them to just give us some final thoughts and one takeaway message, one takeaway that you would like to leave with each of the members of the audience tonight. Jonalyn.
I was very intrigued by Joanne's comment that we die the way we live. And I think we all have choices for ourselves, and I think it behooves us to make those choices known. I know I had blithely assumed that my 3 children were very clued in with how I wanted to be cared for. And luckily, one of my sons recently said to me, "Mom, you know, I can do lots of things for you. I'll take care of your money, I'll put your garbage out, but I just cannot be the one to be responsible for making the decision about how you should continue if you're ill." And he was probably the child that I had assumed may have been had the most ability to do that. So that conversation for me was a gift. And I guess I encourage folks to look for ways to have conversations with people that are important to you.
Thank you. Eileen.
Transformation. That's the key word for me. And it's not just about systems, it's about attitudes. And it is not about someone else doing it. It's about everybody doing it and being involved to create a movement. That type of transformation will be not only about how do you equip and empower yourselves individually, but how do you help this community do it in a broader way. So transformation.
Thank you. Scott.
The notion that there are some things that are uniquely within the purview of a community to take on as opposed to an industry or a profession or a healthcare system really was again driven home to me tonight, and it is over and over again. And with your comment about how important this is to you. So I guess activation and action. I hope that you'll take one personal step, sign up for a class, take somebody with you. It'll make a difference. So.
Joanne.
Yes, my wish for everyone here is to start small and start tonight. On your way home tonight, when you're driving in your car, ask yourself, how do I want to live the rest of my life? Don't think about death. Ask yourself that. And then when you get home, just mention it to someone that you love that you were thinking about it.
Thank you very much. We've come to the end of our allotted time for tonight, and I want to thank all of you for coming out. If you have not already done so, please be sure to fill out the evaluation form about tonight's programs and discussions. And if you have ideas for future issues that matter, please include those on the evaluation. Thank you to our panel tonight, who is sitting here talking with us, Executive Director of the Sno-Isle Libraries, Jonalyn Woolf-Ivory, Reverend Eileen Hanson, Pastor of Trinity Lutheran Church of Mukilteo, Joanne Roberts, Chief Medical Officer of Providence Regional Medical Center, and Scott Forslund, who is Director of the Snohomish County Health Leadership Coalition. When does that coalition meet? How do we get in contact with you? What's the procedure, and how often do you meet?
www.snocohealth.org. And the coalition itself meets quarterly, but that coalition is a group of leaders who's working to be a set of agents for all of us. When that group meets is with that list of courses, for example. That's where the real work gets done.
I ask each of the panelists for what is the takeaway message for tonight, and I will leave you with the 5 things that the Sno-Isle Libraries would like you to know. Think more about the treatment choices you want and who will speak for you if you become seriously ill or injured. Visit snoisle.org/issues that matter and look for this healthcare forum. You'll find out more information about what we talked about this evening, opportunity to sign up for community classes about advanced care planning. Create, sign, provide copies of your advanced care plan and your advanced directive. Give it to your physician, give it to your neighbor, put one around the neck of your dog. Put it on your refrigerator. Make sure that everybody knows where it is and what it is. And talk with friends and family to make sure that they know where it is and that they are doing the advanced care planning as well. Remember, it is not just for you. And again, thanks to our panel this evening. Thanks to all of you for coming out tonight. And thanks to the Snohomish County Health Leadership Coalition, the Sno-Isle Libraries, the Sno-Isle Library Foundation for making us possible to have this discussion tonight. I'm Ed Bremer from KSER. Thank you all for coming out.